Howdy, this is Dr. Richard Bernstein with our December 2020 teleseminar, the last one of the year. Before we go through questions, I want to cover one little article that came out in the past month. It was in the journal Diabetes, and it's another one of these articles that shows damage to the brain caused by elevated blood sugars. I've said before that I've been seeing these articles at the rate of 1 or 2 every month, and it appears that each one of these deals with a different aspect of brain damage. This particular one looked at people who had type 1 diabetes for an average of 21 years. The average age of the people in this group was 36 years, and their brains were imaged and compared. I believe they used a special form of MRI, and they compared the imaging to that of non-diabetics matched for age, sex, etc. And the diabetics had changes which were not found in the non-diabetics. And interestingly, these changes were not related to impaired blood flow, but were strictly neurologic changes. That is, there were neuropathies of the brain. The summary says, no cerebral blood flow differences between groups were found in any of the structures that were examined, suggesting non-vascular etiologies, that's causes of these changes. Our findings implicate a marked non-vascular disruption in type 1 diabetics of several essential neural modes engaged in both cognitive and motor processing. Cognitive is thinking, and motor means movement. Control of motion, I guess, could be balance, could be putting your finger at your nose or something. So it was motion and cognition. And here we have the ADA and most endocrinologists still claiming that if kids have normal blood sugars and low carbohydrate diets, their brains are not going to develop. And we see what's happening with people who are not on our regimen. Now, before we answer questions, I want to remind you that my answers are strictly generic. They're earmarked for the entire listening audience and may not really solve the problem of the individual. I want to mention an experience that happened yesterday where a person who was not my patient, a diabetic lady, phoned my office and asked me for medical advice with regard to her eyes. And I couldn't answer her because it would be illegal for me to give advice without examining her and getting a full medical history, family history, etc., etc. She complained of bleeding in one of her eyes. I think the first eye was already blind. She was diabetic. She had bleeding in the other eye, and now she was totally blind. What can she do? Well, I could have answered her and said, I did say that you should see a retinologist, and she said, well, that's who I saw right away today, and he didn't tell me anything. Well, I knew that a vitrectomy is possible after the bleeding has settled down, when things are quiet, and you're sure that you're not going to stimulate more bleeding, it's possible to suck out the vitreous humor from the eye, which now is full of blood, and replace it with a clear fluid. And for many people, their vision is restored. I didn't know why her retinologist hadn't told her that, but I couldn't tell her because that would be illegal. I would be treating someone who is not my patient. Just giving her advice would be improper. And likewise, the advice I give in these teleseminars is generic advice. I can't claim that I have a solution to a particular individual's problem because it usually is not the case. Okay. First question. I'm type 2 for 30 years, on insulin for 20 years, trying to reduce the amount and finding it impossible to lose weight. So this person has figured out that maybe high insulin doses are associated with weight gain. Following the 6-12-12 low carbohydrate plan and reduced my dosing to 7 units of basal insulin. How can I reduce the amount further and hopefully lose weight? Well, one thing you could do is exercise if you're not exercising. Most people are not engaging in strenuous exercise. Of course, for this person, it might be dangerous to engage in strenuous exercise. So he or she should get permission from the attending physician or a cardiologist, etc. And although this person is on a low-carb diet, he or she may be eating a huge amount of protein. And protein does eventually get converted to carbohydrate. So you could be eating a couple of pounds of meat or fish a day, and that could help keep weight on board. I get restless leg syndrome, but only if my blood sugars are out of control. That's news to me because in all these years, I don't think I've had a single patient with restless leg syndrome. I've recently gotten a cortisone shot for a rotator cuff tear, and my blood sugars were awful and still are high even though I increased my basal insulin. In the past, I had prescriptions of gabapentin and Neurontin, and they made me ravenous like a seven-headed caterpillar. Do you have another remedy? Well, I don't know if the remedy is for overeating, for a rotator cuff tear, or for an answer to the cortisone shot. I can think of several things in the way of advice that I'd like to give. First of all, it is very common for diabetics to have what's called diabetic shoulder capsulitis. I think I was the first one to write about that many years ago. And the treatment is not a cortisone shot. The treatment for that is a trigger point massage or the use of, I'm pointing to my shoulder that has it automatically. It's a lot better now. I've been using one of these electric vibrators, a cordless one, to massage the trigger points in my shoulder, and makes a big difference. I've had this thing for about, about 40 years. No, more than that. It was near the time when I was first married. So that's over 60 years. and I got my right shoulder, the dominant shoulder, which was the most painful one, taken care of way back then, but I didn't bother with the left shoulder, and finally I'm dealing with it now, and it's getting a lot better. So you might want to see a physical medicine doctor, one who specializes in rehab medicine, to make a certain diagnosis. My capsulitis was diagnosed by an orthopedic surgeon initially some 60 years ago without examining it. And he examined it, but did not image it, did not have any proof that it was a rotator cuff tear. And since it eventually responded to trigger point massage, it wasn't a rotator cuff tear. And he injected me with steroid, with cortisone, and I had high blood sugars for 2 months. So if you're overeating, gabapentin sometimes, he's probably thinking of gabapentin for pain. Gabapentin sometimes helps with pain. There are no oral painkillers that I would recommend for diabetic shoulder capsulitis. Rather, I would recommend that you either see a physical therapist, once the diagnosis is made, a physical therapist for trigger point massage, or you, under the auspices of a rehab physician, use one of these electric massagers. I have a 2-year-old fairly new onset type 1 diabetic on 1/2 unit of Levemir in the morning. We started lower carb diet, and his AM blood sugar looks great, but he is having low blood sugar overnight and on a rising. Can I dilute Levemir? No, you cannot. Are there any other long-acting insulins that you can dilute? Yes, there's only one, and it's not really long-acting, it's NPH. You can dilute NPH insulin, and you'd have to probably give 3 or 4 shots a day. You could discuss this with your physician. I have people taking insulins that are diluted 9-to-1, so that each unit is only 1/10 of a unit. You could dilute even more than that, so that each unit would be a 15th or a 20th of a unit. But with NPH, you might need 3 or 4 shots in the course of a day. I have a type 1 child, and we have been at home for 2 months. Do you think it is safe to return to church services during this part of the COVID outbreak? And as I advised people in my November teleseminar, use common sense. It depends upon the provisions made for the church services. Is it outdoors? Are everyone spaced, I would say, at least 10 feet apart? Are they all wearing masks? Under those conditions, my guess is that it would be safe, but it's only a guess. Right off the bat, if you're indoors and if the air is not adequately filtered, and I don't know whether it's possible to find out if it's adequately filtered, even if you're 10 feet apart, you still may be getting exposed. So you have to investigate carefully and use common sense. Don't take any chances. I have an A1C of 5.3%. I see sugar spikes up to 190 after eating any kind of carbohydrate. Am I diabetic? My doctor says this is fine. I don't think so. Well, here's another place where it makes sense to use common sense. It depends on the kind of carbohydrate and the timing of the carbohydrate. For example, if you're eating pure glucose, having a blood sugar of 190 1 hour after consuming the glucose, I think is considered normal by the ADA, provided that in the second hour your blood sugar goes down to a really normal value. When you say any kind of carbohydrate, your kind may not be my kind. I would say that if you're eating bread, for example, and you eat enough of it, you might be able to get it that high in a non-diabetic. But if you're eating string beans, and let's say it's only a cup of string beans, and you go up to 190, I would say you're probably diabetic. My eating is really inconsistent. I have type 1 diabetes at age 32 and a body mass index of 21. I am 37 now and healthy. My eating changes on the weekends, and I tend to eat a lot more calories. I can use a lot more insulin. I never allow my blood sugars to run high. The next days after consuming a lot of calories, my body will require 200 to 300% more for the mealtime and more long-acting insulin. It will continue to stay that way unless I have a 2-day fast. Can you explain to me, and is this a normal phenomenon? I just want to know if I'm normal like any other type 1. Well, I doubt that type 1 diabetes is normal, although at the rate that diabetes is increasing, pretty soon it will be normal for the general population. One possibility is gastroparesis. If you're, first of all, I'm not recommending that you change the way you eat on weekends. I think you ought to read my book and try to keep your blood sugars normal, really normal. That means around 83 milligrams per deciliter, day in and day out, night in and night out. I think you ought to read my book. If you have gastroparesis and you eat a lot, your stomach may take days to empty. So let's say you eat a lot on Saturday, you might be emptying food into your bloodstream all day Sunday and maybe even the next day, and that would cause your blood sugars to go up. That's only a guess. I could be totally wrong. If you read my book, it'll tell you the other symptoms of gastroparesis, and you might be able to figure out if you have it. I've had diabetes for about 20 years. My blood sugars usually stay under 200, but I'm constantly dehydrated even though I drink 64 ounces of water a day. I also drink sugar-free Gatorade on occasions. Because of this, my potassium also stays low. I take potassium every day, but hard to keep my levels up. What else can I do to stay hydrated. I don't know what to do. Well, it sounds to me that this person has polyuria. He pees a lot. Why? Because of high blood sugars. And the game plan should, and when you have high blood sugars and you pee a lot, you'll pee away potassium amongst other things, and we could expect a low potassium. You might also have low sodium and chloride. So my first guess is that you should normalize your blood sugars. When you say you're usually under 200, the renal threshold for glucose is usually around 160. So if your blood sugar is over 160, maybe over 150 even, you could be expected to be urinating to unload the glucose in your blood. I live in Georgia, and our state is reopening during COVID-19. My daughter is 12-year-old type 1. We have been at home since March 13th. Should we continue to stay at home? Well, again, it's a matter of common sense. If in your local area the percentage of positive tests is 1% or less, you're probably pretty safe. There are parts of the country where the hazard ratio is as high as 7% and even greater. So the authorities, the medical authorities, are saying 1% is the upper limit for going out, and even then it's probably wise to wear a mask. Also, should I send her back to school in the fall or find an alternative? She has 2 siblings in public school. Should I send them? And they're youngsters. I would say it applies to all of them. And if the siblings develop COVID-19 and they're put in the hospital and they give them dexamethasone, as they're doing with many people, they could develop diabetes themselves. So basically, going out has to do with whether you're going to be indoors or outdoors, the local incidence, what percent, ventilation of the indoors, wearing masks, and being adequate distancing. And I would say adequate distancing, if you're outdoors, is 10 feet. And if you're indoors, I would say at least 10 or 15 feet. And then only if there's good ventilation and very few people in the room. I take 6 units of Novolog and a sliding scale. I'm following a sliding scale for breakfast, lunch, and dinner. Now, those of you who have tried the ADA sliding scale game probably know that it doesn't work. I'm still finding my blood sugars high, which is frustrating to me. Well, the sliding scale is a ridiculous game where you give people a lot of carbohydrate, and based upon the amount of carbohydrate you're giving them, you give them some fast-acting insulin to cover it. Or another way of using a sliding scale is you only give insulin to cover a high blood sugar. So you eat whatever you want, your blood sugar goes up, and at the number of hours that the doctor tells you, you take a shot of insulin according to his formula, or an ADA formula to bring your blood sugar down. It's a guarantee to have chronically high blood sugars and also very low blood sugars because you really don't know what you're doing. I was told I'm pre-diabetic. I adjusted my diet. I am 33, female, 125 pounds. My recent A1C was 5.3%. I monitor my sugar at home. Recently, I see levels at 170 an hour or so after eating blueberries with unsweetened plain yogurt, and then a bowl of low-carb chicken stew. Would this indicate that I am actually diabetic? Well, it smells like it, but I can't be really sure because it depends how many blueberries you ate. You may have gone out with a big basket, picked a lot of blueberries, and had a pound of blueberries, and that would probably bring anyone up to 170. Why do you think blueberries taste sweet? Because they're loaded with sugar and they'll raise your blood sugar. So I think that you ought to wise up and skip the blueberries. You might want to read my book, Diabetes Diet. I'm a 48-year-old male who has type 1 diabetes for 24 years. I eat high fat, medium protein, and practice intermittent fasting. My A1C is 4.8%. I've noticed an increased sensitivity to protein that causes a blood sugar spike roughly 4.5 hours after consumption. Food such as chicken breast or salad causes my blood sugar to rise from stable 75 to over 180. This is a new phenomenon for me, wondering what can cause an increase in protein sensitivity like this and what I can do. Well, I just had a phone call from a patient whom I am treating. What's it called when you treat over the internet? I'm treating her on Skype, and she had a sudden increase in blood sugars, and happens to mention that 3 weeks ago she cut her finger on a bean can, and now it's infected. So an infection can cause your blood sugars to spike unexpectedly. If you, because you eat a lot of fat and may not be eating enough protein, you may have a diminution in muscle mass. You might have developed gastroparesis, which doesn't come on suddenly, it comes on gradually. Your insulin may be spoiled. You may be using insulin pens and insulin is leaking from the injection site. There are probably a host of possibilities. You might listen to some of my prior videos because we go over many of these possibilities. Offhand, I can't think of more, but I've covered them in the past. I'm 42 and type 1 for 22 years. I work as a builder and wear boots all day long in good and bad weather. I have toenail fungus and now have got it quite severe on my fingernails. Is this related to my diabetes? And is there a remedy for the toenail for the nail phenomenon? Onychomycosis or fungal nails is extremely common in poorly controlled diabetics. I would say about 1/3 of the new patients who walk into my office, whom I examine when we don't have COVID, have onychomycosis. There are several. First of all, although there are medications that might cure it, if you're going to continue to have high blood sugars, it's going to come back. So a key treatment is normal blood sugars. There are several medications. First of all, you could use athlete's foot powder. Frequently, people who have onychomycosis also have cracks between their toes or athlete's foot. So I would suggest that you put athlete's powder on your feet before you put on your stockings or socks in the morning. There's been some success with putting tea tree oil on the nails twice a day. Also, there's been success with Vicks VapoRub, which is not meant for the nails, but seems to kill the fungus. There are a variety of lacquers that you could put on the nails. One brand is called Pen Lac, but there are a variety of them that you could use like nail polish, and you put it on maybe twice a week. There also are oral treatments. There are antifungal pills that you could take, but they have potential side effects. And that's about it. So there are treatments, and it's called onychomycosis. I'm a 19-year-old male type 1 diabetic who follows your diet. My LDL count became very high, reaching up to 300 milligrams per deciliter. What could be causing it, and what can I do besides medication to lower it and reach normal levels again? You can do what I've been saying over and over. LDL is not, the level of LDL is not a cardiac risk factor. Rather, it's the level of small, dense LDL. So you might have all large, buoyant LDL, so you have to get tested for the LDL particle size, and what you want is the large particles. Some of the cardiac tests that you could be looking at that have meaning are small dense LDL, oxidized LDL, lipoprotein small a, triglycerides, HDL, which is good if it's high, high sensitivity C-reactive protein, and homocysteine. These are all common tests that reflect cardiac risk. LDL total is not a significant factor. Is a low-carb, high-fat diet okay for type 2 diabetics? Fat being olive oil, coconut oil, and other good fats. Well, it depends what you mean by good fats. I don't recommend that you live on fats. A lot of people think that vegetable oils are good fats, but they're very easily oxidized. People may not store them properly, and they can actually become harmful. So I would say that you read my book, Diabetes Diet, and work on low carb and high protein, and whatever fats come with the protein would be allowable. Is it possible to do away with my insulin resistance? Well, I'm looking at you now, and you look like you're overweight. In fact, for all I know, you may be grossly obese. So one key, if you're overweight, is to lose weight. Another cause of insulin resistance is infection. So if you have a chronic infection, maybe a root canal or gum infection, that would cause insulin resistance. If you're overweight, exercise, strenuous exercise, helps reduce insulin resistance. Building muscle mass helps reduce insulin resistance. But exercising strenuously may be dangerous, especially if you're overweight. So it would be wise to get medical consultation before you attempt any exercise. Is it safe for an 83-year-old man with stage 2 to 3 chronic kidney disease and an A1C of 5.3 to 5.4 to take small doses of metformin for its many benefits? I would say that since you have advanced kidney disease, or let's call it mild to moderate kidney disease, you ought to consult your nephrologist. He's the guy who should be telling you what to do. Is your book ever going to be updated? Well, we're working on it now, but I'm going to have to live a long time to finish it. Might take 5 or more years because I've been busy doing virtual medicine. I should point out that I invented virtual medicine back in 1984 when I first started practicing. No, it was 83, I guess, when I first started practicing medicine, because my first book had already come out, and there were readers all over the world. And although I'd get them into my office for 3 days to examine them and train them and so on, I could only communicate with them over the telephone. So at the beginning, we did telephone plus fax, and in those days, the facsimile paper would fade out and crumble in about a year. So their blood sugar data sheets wouldn't last very long. Nevertheless, I'd see fax data. I had invented my glucograph form, and they would fill out the forms and send them to me. Now we use email and Skype, and and telephone, and I'm still doing virtual medicine, and I'm pretty busy. So it's hard to get the time to update the book, but we're trying. Is there a link between rising cholesterol, LDL, and increased blood glucose levels? Well, I just got through speaking about blood tests that predict coronary artery disease, and it's not total cholesterol and it's not total LDL, as I mentioned already. My doctor wants me back on a statin due to the higher LDL levels, which I am resisting. My triglyceride and LDL and HDL are well within normal levels. Well, what I'd suggest you do is get the tests that I recently recited and show them to your doctor, and remind him he may not even know that total LDL and total cholesterol are no longer considered risk factors. Is there a risk of atrial fibrillation with low-carb diet? There is with high blood sugars, and there is with severe hypoglycemia. So you don't, if you're on a low-carb diet, you don't want to get severe hypoglycemia, because if you're already at risk for AFib, the hypoglycemia can trigger it. So I would suggest that you read my book, Diabetes Solution, and learn how to keep your blood sugars normal. Is there a vegetarian diet that doesn't use soy for blood sugar control? I cannot recall ever meeting a healthy-looking diabetic on who is following a vegetarian diet. And there are, as you point out, hazards to using soy because it acts like a female sex hormone, like estrogen. And there may be reasons not to be taking it. So, although I don't like killing animals, I think that it's hard to be healthy on a vegetarian diet. Now, if you don't want to kill animals, you could eat cheese and you could eat eggs. So that's an option. Is type 1 diabetes reversible? Not yet. Down the road, there are some possibilities. There are substances that can stimulate the stem cells of pancreatic beta cells, and these natural stem cells are in the bodies of non-diabetics and diabetics, and there are chemicals that, and I can even mention a couple of them. One stem cell are the endothelial cells inside the tubules that secrete digestive enzymes in the pancreas, and also glucagon cells are known to be transformable into beta cells. So the alpha cells are stem cells for beta cells. And the game plan, which is still way down the road, is to give a substance that causes the stem cells to proliferate and to transform to beta cells. But also at the same time, you have to be preventing further autoimmune attack of the new beta cells that come about. So it's not an impossibility, but it's pretty far down the road. This sounds like a question by a physician. A 60-year-old female patient presented with a random blood sugar of 706, polyuria, and mild blurred vision. I placed her on a strict 6-12-12 low-carb diet 5 days ago. I spent 2 hours with her by video conference on education and have called her every day to encourage her. She has been compliant and feels fine. Yesterday, her blood sugar was down to 470 at 9 a.m., 12 hours after breakfast of eggs, sausage, and water, and was 343 at 7:30 p.m., 2 hours after a dinner of pork and broccoli. Her blood sugars remain better overall, down from 706, but still remains high. Would you add an oral medication at this point or continue with a strict diet for now? Is her current high blood sugar coming from stored liver and muscle glycogen? If so, do we expect blood sugar to normalize after stored glycogen is depleted? Absolutely not, because she doesn't have, clearly she doesn't have enough insulin. And in the absence of insulin, you turn your muscles into glucose. It's called gluconeogenesis. So I'm surprised that this is a physician who doesn't know about gluconeogenesis. This person, my guess is she should be on insulin. With such high blood sugars, 343, I would think she needs insulin. So this physician certainly should be prescribing insulin. A 40-year-old female, very athletic and healthy, presents with a BMI of 24.9. So she's a little overweight. She wants to lose a pinch of fat around her belly, hips, and thighs. I started her on a low-carb diet 1 month ago. She has been very compliant, and most days her total carb intake is 10 to 20 grams per day. However, despite her strict low-carb diet and daily exercise, she hasn't lost a single pound. She is so disappointed. Can you explain and or review the physiology as to why she has not been able to lose weight, while so many others are losing weight very easily on low-carb diets? Well, first of all, I would suggest that she be on a constant meal plan. I assume that she's not diabetic, but if she's eating differently each day, it's very hard to establish a weight loss diet. Then there should be planned exercise, not haphazard exercise, but a planned exercise program. And someone should be checking her blood sugars, because if she's got a body mass index of 24.9, she may also have diabetes, type 2 diabetes. She might respond to Metformin, which lowers insulin resistance and can help facilitate weight loss. It can also help reduce hunger. Next question. My 2-year-old daughter has been diagnosed with diabetes type 1 6 months ago. What is the best lifestyle that she should approach to avoid any complications and maintain sugars level in her blood? You should read my book, Diabetes Solution. Keep her blood sugars normal around the clock. It involves low carbohydrate diet. It involves diluted insulins. It involves insulin before each meal, plus basal insulin. It's a lot of work, but it pays off. And the sooner you start it, the more likely you are to preserve beta cells, because once a type 1 diabetic has destroyed all their beta cells, the disease becomes much harder to treat and takes a lot of time, like I spend on my diabetes. If I had known what to do when I was first diagnosed, I could have made my life a lot easier. My husband takes insulin. Before, when he was taking Metformin, he didn't shake at night. Now, frequently he shakes. Is this related to his type 2 diabetes? And so, what can we do? Well, you should check his blood sugar when he's shaking. He might be having hypoglycemia, and hypoglycemia can cause shaking. It can even cause convulsions, which involve real big-time shaking. So the next time he shakes, check his blood sugar and read my book, Diabetes Solution. It looks like he needs a lot of help. My son, 11 years of age, diagnosed as type 1 diabetes a year ago with very little high antibodies, slightly positive. We started to give 1 unit only of basal insulin at night for 2 months. He suffered low blood sugar when we stopped the insulin. No, he suffered low blood sugar, then we stopped the insulin. Sugar was normally a bit high and sometimes low. We started ketogenic diet since 2 weeks and blood all-time normal. Keep keto without insulin or start insulin and suffer from low levels of blood sugars. I'd say that you better read my book, Diabetes Solution. He may not be getting enough protein in his diet. You may need diluted regular insulin before meals. You might need very tiny amounts of basal insulin, like 1/4 of a unit of Tresiba once or twice a day. Read the book Diabetes Solution. Very important. Our son is 11, has just been diagnosed as type 1. He seems to be in the honeymoon period and does not need any insulin on a low-carb diet. Our question is there anything we can do, good foods or drugs, to extend this honeymoon period for as long as possible? Seems to us that with a low-carb diet and no insulin, his chances of hypo or any other complications will be greatly reduced. Sure, his chances of hypo will be reduced, but I seriously question whether he's having normal blood sugars. Now, for an 11-year-old kid, normal blood sugars are about 75 milligrams per deciliter. And I would think that the game plan is to keep blood sugars normal all day long, to give him enough protein so that he grows. You could give the 6-12-12 diet, but in proportion to his body weight. That would be the amount for a 140-pound person. So if he is half that weight, you'd give him half the amount of carbohydrate. And read the book Diabetes Solution. Some of my patients are taking verapamil as recommended by a study at the University of Alabama in Birmingham, and that seems to prolong the honeymoon period. Certainly, normal blood sugars around the clock, and that's around 75 milligrams per deciliter, should preserve the honeymoon period. Some people in our type 1 community are now saying, quote, time in range, unquote, is better than A1C to assess how good a type 1 patient is doing with regard to blood glucose levels. Could you share your perspective on this? Please note that statements seem to come from people marketing continuous glucose monitors and continuous glucose monitor pump systems. They're also being marketed by the ADA, JDRF, and it's being used as a tool to justify high blood sugars. The current time and range that seems to be being advocated is from 70 to 180 milligrams per deciliter. That's the target range. So that range is from slightly low to very high. To me, this is pretty much nonsense. You want people to be normal as close to 100% of the time as possible. So that's my commentary. Female, type 1 for 25 years. And I'm now 56. Well, she's a survivor. My question is about my hands. I have what you call trigger finger on my left thumb. And now my middle finger is starting to lock up on the same hand. Okay, what's happening? She's got glycation of collagen in the tendons on her fingers. And eventually, she could have a claw hand where they all curl over like I'm showing on the video. Usually this starts with the fourth finger, and it's called Dupuytren's contracture. And for many of these people, it eventually spreads to all the fingers. It's a very unfortunate complication. It's due to high blood sugars. And once it occurs, it is treatable with injections of collagenase, an enzyme that dissolves collagen, into the tendon. There are a few hand surgeons who actually give these injections. The injection is very painful, and it's also costly. I came up with my own treatment for this, which is a mixture of DMSO and collagenase, 1 part of collagenase to 6 parts of DMSO, and that you may have to vary the ratio depending upon the patient. You actually do what works. And you apply it with a little brush, like a nail polish brush, to the tendon. Frequently there's a big lump on the palm of the hand where the tendon is swollen. You apply it to the lump. You do it maybe 3 or 4 times a day, and the collagenase soaks through the skin with the help of the DMSO and dissolves the collagen. I've only seen this used on one patient who happened to have been a friend of mine who was not diabetic, but I suspect that he probably had elevated A1Cs. I was not treating him, but he got hold of the formula from his son, who was a physician, and he had it on 2 hands, a big lump on one hand and a smaller lump on the other hand. He did it for a year, not conscientiously, on and off, and the big lump became smaller than the other hand with the small lump. So it may work. Well, that's it for the year 2020. We'll see you in the next decade on Wednesday, January 27th. Have a good month. Stay well. Stay out of trouble. Good luck.